I guess we'll get Kreisel in here at some other point to kind of fine tune what I'll talk about. So let's do a crash course in balloon pumps. I won't go over like all the waveforms and troubleshooting from that regard. That should really involve like the MDs and everything. But with any intervention that we do, it's really important to know why we're doing it, what we're trying to achieve, and what do we do when things go wrong. So I took a couple of notes here on my phone here, so I'm going to be kind of referencing it. But balloon pumps, why do we put them in? And this is interactive, so shout out answers, whatever. So why do we put in balloon pumps on patients? To open the RV?
The artery and the heart.
Okay, give me a little bit more on that.
Like increased perfusion to the coronary arteries.
Increase perfusion to the coronary arteries. So let's back up. Why would the coronary arteries need help in terms of perfusion? What happened to the patient?
Got occluded
MI, right? So we usually see balloon pumps being placed in patients who just had heart attacks, all right? Could be other conditions why we would place in a balloon pump. So MI is number one. You told me it would help out with the RV, so it would help out with the squeeze. So what other conditions?
like a heart
Patients.
failure,
Heart failure, somebody with low cardiac output, right? So those are the two big ones, okay? So people that have just had MIs, they have blocked coronaries that just got stented open, and they have occlusion of other coronaries, they need better perfusion there. People with low cardiac output, those are both conditions where we should place an intra-aortic balloon pump, right? Or we would think about it at least. So really, we're asking ourselves, what is it doing, right? So again, we talked about how it helps with perfusion of the coronaries. We talked about how it helps increase cardiac output. So how does it do that, right? So first of all, we talk about where it's placed, all right? So it's placed in the cath lab, literally, more often than not, but I have seen it placed at the bedside. We used to place them at bedside where I trained. But anyways, usually the access is through the femoral artery, and we go up and we place the balloon pump in the aorta, but we need to make sure that it's placed in a specific location, right? We don't want to place it too high, we don't want to place it too low, right? Placing it too high, there is a pretty important takeoff of the aorta, your left subclavian, right? That sends blood up high, and then you have your renal arteries, right, a little bit lower, that help feed your kidneys, right? So you can already think about some of the things you need to monitor for when that balloon pump is in place, right? So you're looking at the patient's mental status, you're looking for neurological changes, you're looking for perfusion in the arms, you're also looking at urine output as well. If you see some changes there, one of the first things you need to be thinking, is my balloon pump too high? Is my balloon pump too low? So we place the balloon pump, right? And then the first thing we need to do is get an x-ray after we place it, right? To make sure that it's in proper place. And then we're off to the races, right? So the main thing we're trying to do is make sure that this balloon pump is now inflating and deflating at specific times, right? So the way that we do that is by hooking the patient up to EKG leads, right? And monitoring their electrical cardiac activity, right? But when do you think it is important for this balloon pump to inflate and deflate? Let's talk about inflation first. When should this balloon pump inflate? So if we're coordinating the inflation and deflation with the squeeze of the heart, when should this balloon pump that is sitting just past the heart, when should it be inflated? When the heart is squeezing or when it's relaxed? Those are your two options. When should it be inflated? When it's relaxed, right? Because if the balloon is inflated while the heart's trying to squeeze, we have a problem, right? So, exactly. So, more specifically, we're trying to inflate this balloon just as the heart is relaxing, because in that point, we are trying to cause a little bit of backflow to the coronaries, right? We're trying to cause a little bit of backflow to the coronaries. I can think of a situation where you might want to, in that case, think about not placing a balloon pump, because in patients with severe aortic regurgitation, if we're trying to cause backflow with this balloon pump and the patient has severe aortic regurgitation, we can exacerbate that problem. We can make it worse. So that's another pause for concern there when we're talking about balloon pumps, okay? So if we talked about inflating the balloon while the heart is relaxed, when should we deflate it? When the heart is squeezing, right? So there, we're trying to improve cardiac output, all right? Not going through the whole physics and all that, but if we are deflating while the heart is squeezing, we're actually helping with afterload. We're actually causing like a little kick, some blood to, a little bit of blood to shoot out from the heart than normally would, okay? This change is not really significant, which is why when we were setting up this talk, there's actually some talk about balloon pumps like going a little bit out of favor, because there's other ways that we can, or better ways that we can augment some of the afterload here, but it does give that help, okay? But those are the two main big things to remember. So we are inflating during diastole, we are deflating during systole, okay? And the way that we're doing that, or the way that we're monitoring systole and diastole, is through the EKG leads, okay? It can sense when we're supposed to be in systole and diastole as well, okay? So what you're gonna see on the monitor, so you're going to see 3 waveforms, obviously. You're gonna see the EKG leads, and then you're going to see the pressure in the balloon, or the pressure with the patient, excuse me, and then you're also going to see the augmented pressure after everything's said and done with the balloon inflated versus deflated, okay? So what you should see, here is in a normal waveform, and let me pull one up for you just so you can kind of see it labeled here. What you should see here is in a augmentated and a normal waveform here, you should see this is a 1 to 2 frequency, meaning that for every 2 beats, 1 is getting augmented, okay? And so the diastolic augmentation should be a little bit higher because you're getting that kick, okay? Because when the balloon is deflated, you're getting that kick, you're getting that extra squeeze, okay? So that should be a little bit higher. So this is a normal waveform that you should be seeing. This isn't a normal patient, okay? And then this is the patient's native pressures right here, and this is the EKG waveform, all right? Again, not getting into too much in terms of specific waveforms and knowing what's going on into troubleshooting. That's a little bit more on a call the provider sort of situation. But things to look out for, we have kind of already talked about. So one thing to note is that in your setup here is that you have obviously your tracer leads, your EKG leads, and then, oh, that's where they're teaching here. But one of the questions I have for you guys is that this balloon is inflating and deflating, but we already talked about it already, where you have a gas that is in that balloon, helium, right? Why do we choose helium over like oxygen or anything like that? Why do we choose helium? Helium is light. Helium is super light. We need this balloon to inflate and deflate pretty quickly, right? And so if we are needing to do that, it's fast, it's mobile, and more importantly, one of the other things that we need to start troubleshooting is, you see this thin balloon here, there's a chance for rupture, okay? And so if helium gets into the system, our bodies can deal with that a little bit better, okay? But other considerations to look out for is that when we're placing a balloon pump or any big foreign object, as you can imagine, that is a good setup for potential clots, right? And so one of the things that we often do with these patients is put them on a heparin drip. So that's another one of the considerations that you need to think about before placing a patient on a balloon pump. Can this patient tolerate a heparin drip? Obviously, we need to monitor those levels as we are keeping the patient on the balloon pump. You need to monitor for limb ischemia, good perfusion in the limbs, especially the groin area, the limb that the balloon pump was accessed for. Positioning, you want to make sure that the patient is about 30 degrees sat up in bed, or less than that, I should say. So 30 degrees or less, because if they're sitting up a little too high, obviously that's a good opportunity for this catheter to bend, so you need to keep that in mind. And we talked about it already, where one of the potential issues is the perfusion to the kidneys, so you need to keep a good eye on the urine output and obviously the patient's neurological status. So we talked about situations or potential situations where this begins to not capture as well, and we kind of walked through a couple of these before we even started talking, where we started messing with the waveform here a little bit. So obviously this flat line is not good, and you can see the correlation though, right? So if the balloon pump is not picking up any sort of electrical activity, it's going to stop working. And it's going to start beating like crazy. Okay? And then alarms you might hear. You just heard one where it's not capturing electrical activity correctly. Another big one to look out for in terms of alarms is a potential gas leak. Okay? So this monitor can sense if you have some helium leaking out of the system. That would insinuate a potential balloon rupture, and we need to get that evaluated pretty quickly. Loss of trigger, that is implying that one of the EKG leads might have come loose, and as you can imagine, if we are trying to correlate each pump with the electrical activity, EKG leads coming loose is a big problem. The other big thing to look out for is look at your tubing as well, okay? Especially your helium tubing, all right? If you start to see blood in the helium tubing, we have a problem, right? Because that's probably indicating more of a gas or a leak, a rupture, balloon, and we need to get that evaluated pretty quickly, okay? That's the quick and dirty of it. Again, I don't want to get too much into tracings today in terms of identifying the potential issues there, but from a nursing standpoint, it's important to understand the different alarms where there might be a problem in terms of the EKG leads not capturing correctly. We might have a problem in terms of not aligning the inflation and the deflation of the balloon pump to the actual pressures and the electrical activity. That is a problem. We might need to augment the pressures a little bit, or we might need to change the timing on things a bit. So that's a potential issue to look out for, and obviously look at your patient, right? Neurological status is getting worse, urine output is decreasing, we have a problem as well, okay? Those are the big things. Again, we went over the reasons why you place a balloon pump, how we place the balloon pump, what to look for in terms of troubleshooting, and just a quick and dirty over the couple of different waveforms here. The other thing to mention, obviously on a daily basis, you want to check the groin site. Not even on a daily basis, more frequent than that. You want to make sure you check the groin site, make sure that there's no developing hematoma in that area. The dressings are clean, dry, and intact. You want to make sure that on x-rays, whenever we obtain those, you can absolutely pull those up and make sure that the balloon pump is in proper position. If there's any questions on that, please contact the provider. But that's really the quick and dirty from our end of things. Questions on that? Clear as mud. But, you know, again, in setting up this talk with Dr. Kreisel, you know, he kind of mentioned offhand that, you know, the cardiology realm might be starting to move away from balloon pumps to some degree, but with that said, this is something that we still see here, okay? So there should be some level of familiarity with us in terms of managing this, but the main thing is, from y'all's standpoint, just watch the patient, watch the monitor, watch the alarms. If this starts alarming in terms of lead captures, or if there is a change in this beautiful waveform here, then we need to get that addressed, okay? In terms of weaning off, that's one other thing I didn't talk about in terms of weaning off the balloon pump. Right now, we're pretty much at a 1-to-1, but some cardiologies folks will change that to like a 1-to-2, so like for every 2 beats, you'll get some augmentation, and then, you know, it will kind of move forward in that direction, 1-to-3, that sort of thing. So, and then some folks just go ahead and pull it. So, with that said, if there's any questions, you can always reach out to one of the providers. Like I said, I'll probably touch base with Dr. Kreisel, and he can fine-tune some of this talk here. We'll send out some other tidbits of information. I think we'll post this video online so y'all can kind of access this. But that's all I got for you guys.
Thank you.
All right, cool.
Thank you.
Thank you, guys.